Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of pregnancy and epilepsy. Dr. Travis Brown, we typically tackle one thing at a time on This Medical Life. You've brought two together, epilepsy and pregnancy. Why so?
So this episode was inspired and assisted by Dr. Amber Moore, and she's an obstetrician and gynaecologist. And I saw an Instagram post which really caught my attention, and it was about a patient who was pregnant and had epilepsy. And the reason why I wanted to do this episode, or this double feature, is because sometimes I think it's great to do really broad topics. Sometimes it's like to do really good narrow topics to really help out those people who actually have the condition and can have a resource to listen to. And so pregnancy and epilepsy is one of those things that unless you've actually encountered it, you don't think about it at all. And epilepsy is such a huge topic. I have yet to sort of embark on it as its own episode. So I saw this as an opportunity to look at just one aspect. How do patients who are pregnant wanting to have their family, how do they manage? What things do they need to think about, even pre-conception, conception, post? And this was why we're going to talk to a few patients, get their experience, learn about what their concerns were, see what we can learn for other people. Because I imagine a lot of people with epilepsy, particularly women, when they're growing up, might even be a bit hesitant to ask or a bit scared of what the answer is. Can I have a family? What does it mean for me if I'm pregnant, my partner? And so this was just one of those things, and epilepsy being so large, I just wanted to tackle one aspect of it.
And of course, with pregnancy, your body is pushed to its extremes, and then if you're fearing that you might have a seizure or some sort of event when you're already in a taxed state, I guess that is what's playing on the mind, isn't it?
And not only that, it's one of those things, how will it impact me? And then if will pregnancy itself make me have more seizures, or will this be, or can I not even, or should I not even go down that path, depending. And so this is just shining a light on one aspect of epilepsy, which is really large, and a topic in itself, and just seeing, look, again, there clearly has been a lot of patients who have epilepsy have families, and so it isn't a prohibiting diagnosis, but there are some things to be aware of, some issues to raise, and for patients to know about.
And I guess the key thing here is, as I went through parenthood, is it's the moment when you transition from only thinking about yourself and I will bear consequences of whatever happens, to knowing that you've got that direct responsibility for another being.
Yeah. And this is the thing. It's not just, this will be a true multidisciplinary approach. This will be having a general practitioner. This will be having an obstetrician. This will be having a neurologist. This is generally, that Venn diagram and the patient sitting in the middle. And not just the patient, a pregnant patient and children beyond that. And to the other point of, well, can I have more than one child? Well, yes. And so this is, again, just probably for me, just the perfect sort of a very specific subset of patients that if someone does have epilepsy, you can say, here's this resource, have a listen if you're ever thinking about having a family. And so that's why I wanted to put this together.
Daisy Beyer lives in Melbourne with her husband and son, who are expecting their second child in August 2024. Daisy is a registered psychiatric nurse working at St Vincent's Hospital in Melbourne. She's living with generalised epilepsy that was diagnosed when she was an adult. Daisy is a patient of Dr. Amber Moore and Professor Mark Cook, who will be talking to you later in this episode, and has a lived experience of managing epilepsy throughout pregnancy, navigating postpartum and subsequent pregnancies. Daisy's our guest on This Medical Life podcast. Daisy, welcome.
Hi, thank you for having me.
Now, Daisy, I mentioned adult before. When were you diagnosed with epilepsy?
Yeah, so I was officially diagnosed with epilepsy in 2020 when I was 30 years old. So it was a bit of a surprise. I did have an initial episode of seizure activity when I was about 23, which was investigated but deemed to be non-epileptic related. And then we just saw a very gradual increase in some seizure activity over the years, which again was deemed to be sort of one-off episodes. And it wasn't until about 2019 when there was a significant increase in seizure activity that my GP referred me to Professor Cook. And he took a very detailed history and said, this sounds like adult onset epilepsy. And he was right. And it was a bit shocking as a 30-year-old to find out that you have epilepsy, especially with no family history, and trying to navigate that part of your life.
How long did it take for your epilepsy to become well controlled then?
Yeah, so it probably took about 12 months for it to become well controlled. In that time, so when I was diagnosed, my husband and I were planning to start a family. So it all sort of happened at once. And then in pregnancy, the risk of seizure does increase. So we did see some increase in seizure activity during that first initial 12 months. And it took 12 months for it to become stable and controlled, managing day-to-day life, and then sort of hit any road bumps and sorted that out along the way.
When you were diagnosed, when did pregnancy and having a family actually crop up in your thought as, is this going to be an issue for us having a family?
Almost immediately for my husband and I. So when we sort of met with Mark and he took that history and was very confident that this was adult onset epilepsy, it was one of my first questions that we are wanting to have a family. And working in mental health, we do use some medications that are similar and treated for mental health issues as well as epilepsy. So I was aware that there were some medications that were not recommended for women of childbearing age, and the concerns that could have with pregnancy. So that was immediately a question of mine of how do we discuss this and move forward. And Mark was very patient and answered all of my questions and gave me a lot of information, and said, this is something that you can definitely do, and this is something that we can manage, and there are ways around that.
Did you have any hesitancy about whether to have a family or not? Because that seems to have been in the past. Some education had been a little bit skewed, and people thought epilepsy and pregnancy did not mix. Did that ever actually worry you?
It did to a certain degree. Definitely wondering about what the medication options would be, because as I had said, there was a significant increase in seizure activity, and that was quite worrying in itself, just living day-to-day life. And controlling that was something that was very important to myself and to my family. So having that conversation, really trying to understand what the options were, because some options just didn't seem, for me personally, like it was something that I was willing to explore, knowing that there would be significant risks to a pregnancy. But then with the medication that we did, I ended up going on and discussing with Mark, it alleviated a lot of my concerns. And there is definitely sort of like a rabbit hole that you go down when you're first diagnosed, you're talking about medication, and the internet is really not your friend in those moments. So you can spiral quite a bit, thinking about what is going to be the best option. And at that time, unfortunately, there was quite a lot online, even though it was only 4 years ago, quite a lot online deterring you from pursuing pregnancy and having a family. And that is also quite confronting in itself. So when you're overwhelmed with information and it's something that you really want in your life to pursue a family, reading that is quite confronting. So having people like Professor Cook and, Amber Moore to bring you sort of back down to reality and discuss those things with you was really important for me, and then made me realise the importance of having a family and how we can sort of navigate that.
We are speaking to Dr. Amber Moore, and she's helped us set up this episode. How was your interactions with her? How did that was it any different than what you would expect from a sort of a normal non-epilepsy related sort of interviews or meetings, appointments? Yeah.
Yeah. So I was referred to Amber through Mark. So initially, when I spoke to Mark and said, I want to have a family. And it wasn't actually too long after that I fell pregnant. And I consulted him immediately, and he said, I've got this wonderful obstetrician, go see Dr. Moore. And I was like, great, no worries. And I went into that first appointment really sort of unsure of what to ask and what to do. And Amber was incredible. Like, she is incredible. She immediately asked me how I was feeling about pregnancy and epilepsy, and then immediately explained to me from her perspective what could occur, what might happen, what we might be looking at down the path, of pregnancy, and wrote this incredibly detailed plan that I actually still have 4 years on, that I still reference quite a lot, about if you do have a seizure, this is the steps that she would recommend following. With one of the, I suppose, things that is consistent is always contact her and let her know. And just for, I suppose, peace of mind and reference. And every time that has occurred, it's just to provide reassurance that things are okay. So I wasn't too sure what to expect in that initial meeting, but I walked out feeling very empowered and confident that this is something that we can definitely do, and we have the right team and the right supports to do this. And that was really beneficial to making that decision to build a family.
How did your pregnancy go?
My first pregnancy, it did have a few hiccups and it was a bit complicated. So my epilepsy was relatively well maintained until about 3/4 of the way through. And then I had a sort of string of 3 or 4 seizures that sort of, they became more intense, I suppose, as they went along. And that was quite confronting because you sort of, through this first period, when you're pregnant, that it can increase the risk of seizure activity. And you sort of get comfortable when you haven't actually experienced a seizure until towards the end of the pregnancy, and then things start to concern you. So I had a few seizures, and they impacted me more than the baby was fine. The baby was completely fine. And I, every time, was able to speak to Amber, and she was able to reassure me. And she's also just incredibly kind with her time, and would bring you in the next day or straight away and scan you and make sure that you felt that everything was okay and knew that things were fine. The pregnancy ended well, and I have a beautiful, healthy little boy, but it was, had a few complications, especially with epilepsy.
With those seizures that happen during pregnancy compared to those before pregnancy, I imagine they are profoundly different, because in the former case, you just worried about yourself. In the second case, I'm sure you're thinking about the co-pilot who's on board with you.
Absolutely. And you almost put yourself to the side completely, and your whole focus is on this baby, and are they okay? My previous experience had always been that, so I actually don't get an aura, or I don't have any sort of sign that I'm about to have a seizure. It's mainly that my dog starts barking and I'm already sort of disassociated from that, and then alert somebody else that in the house that this is occurring. And I have no recollection of it. So prior to pregnancy, of course, you worry about yourself and you worry about the situations that you're in and the environment that you're in, and if that could impact how you recover from that seizure. But in pregnancy, for me personally, you just sort of lose that fear for yourself, and you're so focused on this baby and the outcome that's when you sort of come to and you learn that you've had a seizure, and you might, whether it's you're in hospital or you're in an ambulance or wherever you are, and the concern is immediately, is my baby okay? And it's quite a difficult thing to process until you can get some recognition that the baby is fine, or someone can tell you that, you know, the heartbeat's strong or everything's okay. And that's why I guess having that benefit of calling Amber and her saying that baby is so well protected, it's going to be fine, just focus back on yourself, is really beneficial. But you really do sort of need that support from someone to say, you also have to pull yourself back into this and look at your own well-being, because that is also going to impact if you will continue to have seizures, and if that will, you know, how you look after yourself impacts that tremendously.
After the birth of your child, how was that? How did you find that?
So my epilepsy is mainly triggered by sleep deprivation, which is essentially
parenthood.
Yeah, so you are always awake. So my husband and I had a lot of conversations about how we would manage that time. I was quite anxious going into that about what if something happens when I have this baby and I'm by myself. So we just had to make some accommodations at home for that, really. And my husband took more time off work than, you know, we're very sort of lucky that he was able to do that in that initial period. And we just had to make adjustments for our family so that I was able to sleep and be rested enough to look after a baby safely. But it is quite difficult to process. And, you know, also talking about there's so much that is public opinion in pregnancy and postpartum, and how to do things, I suppose, in what people deem correctly, that you have to really bring it back to your family and what's going to work best for you. And we were like, I really wanted to breastfeed, but I knew that I couldn't be up all night breastfeeding a baby. So we had to make some concessions around that. And we had a really great neonatal pediatrician who really helped guide us through that and really emphasized the importance of sleep and rest, and that benefit was going to be, you know, the benefit of that was going to outweigh any risks of not breastfeeding. And that was, you know, you can logically understand that, but having someone who's really patient and calm and explaining that to you, in those moments, you really need someone to ground you and bring you back to that. So that was really important.
You're on your second pregnancy now. How do you feel going into this one?
Yeah, I felt pretty confident going into this one. I felt like despite some of the hurdles we faced in the first pregnancy, coming into this pregnancy, we were more informed. We had a lot of information. We had that lived experience as well of having managed seizure activity during pregnancy and then postpartum as well. So we felt pretty confident that we could manage anything that arose during a second pregnancy. And we learned a lot from the first pregnancy. We learned that sleep is important, taking more time off is important. And we were really comforted by things that had occurred well in our first pregnancy. So we had additional scans to make sure that there was no concern around development of the baby, which, you know, is a big concern with these medications as well that you take. You know, and increased monitoring, more frequent appointments, just essentially for peace of mind. So we felt that first experience, despite some of the hurdles, was so positive with our healthcare team that we felt really prepared to manage a second pregnancy.
Daisy, just in closing, is there any final advice or comments that you might have for doctors or even for patients who have epilepsy that may either be pregnant or already be contemplating pregnancy?
Women contemplating pregnancy or who are already pregnant, information is power, and there is so much in pregnancy that for anyone living with epilepsy or not, that you just cannot control. And getting the information that you need, making informed decisions that suit your family and your unique situation helps you to regain some of that control. So I think that's so important, and having a healthcare team that really understands what is important to you, and supporting those decisions that you make, whether it is to stay on medication, whether it is to come off the medication, whether it's to increase medication dosage, whatever those decisions are, having someone who's in your corner who understands why you've made those decisions is really important. And using all the resources available to you. I would recommend not Googling, and I would recommend speaking to people who either have that lived experience or your healthcare professionals who are going to support you in what you decide to do, and really trying to drown out that noise of public opinion, because every situation is unique and every situation is so different that you can only decide what is best for you and your family. Everything else is just noise, and just knowing what the risk and the benefit is. And so and that might be completely different for someone else. And you can do it. You can, if you really want to have a baby and you have epilepsy, there are options available to you, and there is great support available to you to be able to do that. And finding those people to really support you and back you is going to make the world of difference when you are at that point in your life.
Wow. Daisy, all the best as you approach the next birth.
Yeah, thank you.
And also part of that advice about ignoring Google and listening to the wise people around you probably could be used universally at the end of every episode, I think.
I think so, yeah.
But Daisy Beyer, thank you so much for joining This Medical Life.
Thank you so much for having me.
Dr. Amber Moore is an obstetrician and gynaecologist in full-time private practice. She consults at St Vincent's Private and Epworth Hospitals in Melbourne, in Australia. She's also a member of the senior medical staff as a consulting gynaecologist at the Royal Women's Hospital. Dr. Moore has previously served as a federal councillor for the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, holding a number of committee positions, including Women's Health Committee and the Continuing Professional Education Committee. Dr. Moore is a current member of the Australian Gynaecology Endoscopy Society. She's also completed an undergraduate law degree with honours and a Master of Laws, both from the University of Melbourne. And Dr. Amber Moore is our guest on This Medical Life podcast. Welcome.
Thank you. I'm honoured to be here.
Amber, can I start by asking, how does management of these patients we've been talking about who are pregnant and have epilepsy differ from those who don't?
The most important and vital ingredient of caring with a woman with epilepsy is preconception management. So whereas I encourage all women considering a pregnancy to have a checkup with a general practitioner or an obstetrician or a midwife prior to getting pregnant, with women who live with epilepsy, it's really critical. And it is the key really to a successful pregnancy and a safe and successful birth.
What are the most common questions you get asked from patients about this?
The single most common question is really, do I have to keep taking my medications because I'm worried I know they can cause problems or abnormalities in my baby? So can I stop taking them? And if I do have to take them, what effects are they likely to have on my baby?
So you said preconception, but when is the ideal time for a patient who has epilepsy to come and have these discussions, either with a GP or a gynaecologist or obstetrician?
Look, the earlier the better. I mean, I have some women who I will see even a year before they're planning to conceive. That's probably, well and truly ahead of the game. But look, I would at least recommend about 3 months beforehand, because the things that we want to put into place take months rather than days or weeks to sort out. There's a couple of things that are really critical, and probably the first thing is to get women onto folic acid. Now, women planning a pregnancy know that they should be taking 0.5 milligrams or 500 micrograms of folic acid daily in the lead up, either ideally 1 month pre-conception and 3 months into their pregnancy, to reduce the risk of neural tube defects. And that's been an incredibly successful preventative measure that pregnant women can take to protect their babies from spina bifida and associated neural tube defects. However, women with epilepsy have other things to sort out as well. And generally, we would recommend they go onto a higher dose of folic acid. Now, in the past, we would recommend even up to 5 milligrams or 5,000 micrograms of folic acid, which is 10 times the regular dose. In fact, especially with some of the newer anticonvulsant medication, they probably don't need to take a dose that high, partly because the newer anticonvulsant medications don't induce liver enzymes to the same extent. So we would generally recommend 2.5 milligrams daily, with probably a minimum of 800 micrograms. But as a general rule, I recommend women take 2.5 milligrams a day. Used to be 5, now I take 2.5. However, I have to reinforce to women that when they go to the pharmacy, to make sure they do get the higher dose. And it's really cheap, so it costs about $7 or $8 to buy a little bottle of Megafol, which comes as a 5 milligram option, and I just get them to cut it in half with a pill cutter, or just snap it in half. So that's probably the first thing, to get them onto folic acid, because we know that if they are on anticonvulsant medication, one of the significant increased risks for fetuses is the increased risk of neural tube defect.
Just before we move on, because you're talking about the supplements, and before you mentioned that one of the most common questions is, what do I do with my medication? What is the short answer to that, if there is one?
The short answer is you need to get your epilepsy under control with the lowest dose, ideally single mode medication possible. So what we aim for is monotherapy. So if possible, we use those months prior to conception to rationalise their anticonvulsant medication. And that means speaking to their neurologist about, if possible, either getting off medication that may be of a higher risk profile, or rationalising their medication from, say, 2 medications down to 1, if possible.
From a perspective, now I'm trying to work out with this almost multidisciplinary sort of approach, is epilepsy considered one where a general practitioner will almost automatically refer to an obstetrician, gynaecologist and neurologist at the same time? I'm just trying to think of that initial step that they should be taking if a patient comes who has epilepsy and says, I want to be pregnant. Is that an automatic referral to a neurologist and an obstetrician?
Well, in most cases, women with epilepsy will have been under the care or continue to be under the care of a neurologist anyway. So it may be as simple as speaking to the neurologist and saying, go back to your neurologist and tell them that you're thinking of having a baby, and ask them to look at your medications. And alternatively, I think it is actually important if general practitioners are seeing women who live with epilepsy who are of childbearing age, that they actually ask that question and promote that right from the get-go and say, look, do you have any plans for family or for children? And partly because preconception advice is so important, and sometimes because contraceptive failure will lead to the presentation of a pregnancy. And one of the tricks, if you like, is that women who live with epilepsy, the pill is not necessarily as effective. So therefore, their risk of contraceptive failure is higher. So the possibility of an unplanned pregnancy is higher because their contraceptives may not be as effective. So, for example, even having something like Depo-Provera injections, we recommend they have them at a shorter interval, 10 weeks apart rather than 12. We know that if they're they shouldn't take the mini pill. Their combined oral contraceptive pill may need to be of a higher dose, or in some cases even doubled, in order to maintain the same contraceptive benefit.
What concerns are there for a patient who has epilepsy, who hasn't done the preconception planning or anything, and becomes unexpectedly pregnant?
One of the things that I think is really important for all practitioners to be aware of is this is not just about the baby. This is about the mother as well. And I think one of my concerns about the management of epilepsy in women who live with it, often from a very young age, and have often heard all the horror stories and have anxieties about it, is all the focus is on the fetus and not on the well-being of the woman. So as in the first instance, an unplanned pregnancy may represent and be associated with other things such as non-compliance with medication, not being on a suitable contraceptives, thus they have an unplanned pregnancy, not obviously taking folic acid and therefore unnecessarily exposing their growing fetus to an increased risk of neural tube defect simply because they're not on that additional supplement, as a lot of women are not, even if they don't have epilepsy. But it's also because, although as a general rule, the your seizure activity won't be altered simply by being pregnant, with advancing pregnancy, depending on which medications you're on and how compliant you are, it may be that you'll expose yourself to a higher risk of seizure activity. So I suppose the factors around all that are related to lifestyle and compliance, which puts the woman at risk. And particularly if a woman has had relatively well-controlled epilepsy, has an unplanned pregnancy, panics about taking her medication, stops her medication, and then has a seizure, that can lead to her losing her driver's license, and her whole lifestyle is suddenly significantly affected.
Is there any additional monitoring that patients need other than routine pregnancy bloods and scans?
First trimester is all about making sure they've got the folic acid on board, and then discussing and rationalising medication, but not rationalising it such that you put a woman at risk. So that's where it has to be done with the cooperation of the neurologist. Second trimester is really when we will zone in on abnormalities associated with anticonvulsant medication, and I would generally recommend women should have that 12 to 13 week ultrasound that they normally would, looking for really significant neural tube defects or major cardiac problems that are very obvious. And then it is recommended they have a very good quality ultrasound at around 20 weeks, ideally 21 weeks. I personally think it is an appropriate thing to do an early second trimester scan as well. That is not something that's necessarily standard, but I think doing an early second trimester scan at 16 or 17 weeks is appropriate, because sometimes the fetus is too small to see, for example, a cardiac problem at 12 or 13 weeks, and by 21 weeks it might be very obvious, but it becomes very late to deal with something that might represent a significant risk post-delivery. So 16 to 17 weeks will give you a good idea of exactly what you may be dealing with. And then in third trimester, our monitoring is more or less the same as it is for in terms of the fetus as opposed to other women who don't have epilepsy. And then we start to gear up for, the special consideration of delivery in the postpartum period.
Is there any differences in birthing plans for women?
Look, as a general rule, Caesarean section is done a lot more commonly for women who live with epilepsy. However, that is not because of their epilepsy. So we don't recommend delivery by caesarean section for women with epilepsy. And I think a lot of patients I see are actually quite surprised by that. I think they come in as just assuming they'll probably have a caesarean section. And in fact, epilepsy is not an indication for a caesarean section per se. And especially in women under the age of 30, like the younger a woman is, I think it's you'd have to really think carefully about recommending a caesarean section because of the potential long-term issues with ending up with multiple caesarean sections, especially more than 4. So we would still recommend a vaginal birth and caesarean section on obstetric indications alone. However, when it comes to birth, we are looking to make it as controlled and planned as possible. And so one of the things we want to avoid is any triggers. And the biggest trigger for women who live with epilepsy is sleep deprivation. And you may be aware that labour can cause a lot of sleep deprivation. In fact, the postnatal period can cause a lot of sleep deprivation. So having a planned birth has some benefits, and it's not crucial. If a woman comes into spontaneous labour, we would aim to give her as much rest as possible, keep the lights down, give analgesia earlier. Ideally, even give an epidural earlier so a woman can get some sleep during the labour. So we're avoiding triggers that might increase their chance of having seizure activity, although the chance of actually having a seizure during labour is like 1 to 2%. It's actually very low. So we don't want to be overly or cause an over degree of anxiety for women about having a seizure in labour, because most of them don't. However, avoiding those triggers is important, and therefore sometimes induction of labour where we can plan it, we can make sure a woman gets an adequate sleep the night before, all of those things, and keeping the lights down, as I've said, is important to reduce the risks of seizure activity during childbirth.
Is there any difference in the postpartum management for patients?
Look, it's mainly about education, and that is really with regards to, apart from all the normal things that women need to learn postnatally, which is vast, and also their partners. And don't forget, part of this is also educating the whole family, because it's not just about women who live with epilepsy who have to deal with the after effects. It's actually about engaging their partner and having the family prepped for the birth. So, for example, what I strongly recommend when I'm dealing with a couple is that the partner knows that they might be doing the 3 a.m. feeds. And so early on, we get into a little bit more of a regimented pattern of childcare, so that those feeds can be done. So mum, if she's breastfeeding, and we generally do recommend women breastfeed. In fact, most women who are on anticonvulsants, we want them to breastfeed because there's not strong evidence that it is harmful. And in fact, there's evidence that breastfeeding is beneficial to women, even if they're using anticonvulsants. And so the sort of neurocognitive benefits associated with mother looking at her baby during breastfeeding and eye contact and closeness is definitely beneficial. So what we want is for women to maintain their breastfeeding, but then ideally to have a sleep. And every woman who has epilepsy may have a different need for sleep. And for most women, sleep deprivation is the biggest trigger for seizure activity. So we would want them to get 6 to 8 hours sleep. Even 4 solid hours at a time is beneficial. So that might mean expressing. Some women antenatally express milk, or they might express some extra during the day so that they've got express breast milk ready for them in the middle of the night, so that their partner can feed the baby in the middle of the night, so they can get an uninterrupted session of sleep, and then they get up in the morning and feed again and express if necessary. It's also about educating the family that, for example, women can bathe their babies. Some women, even now, it surprises me that women with epilepsy think they're not allowed to. They're definitely allowed to bathe their babies, but we just take the precaution of you should only bathe the baby when you've got a second adult responsible person in the house who can kind of keep an eye on things and make sure if you have an unpredictable seizure that you're not unsupervised with a baby in the bath. But doing normal things like breastfeeding and bathing your baby is really, really important for women who have epilepsy. Things like changing their babies on the floor, especially if they're on their own during the day. So rather than having a change table, just putting the mat on the floor. And, you know, for my old knees, I'd struggle to get up from the floor changing a baby. But, you know, for young, fit women, it's not a big deal to either change the baby either on a bed or on a low sort of double bed with the babies in the middle, or to change them on the floor. So it's sensible things like that you have to sort of educate not just a woman who's given birth, but the whole family, so that they're aware of those limits.
What a journey. Before we leave, is there any final advice or comments you'd like to share for doctors, you know, general practitioners in this area?
There's probably a couple of takeaways. One is not to be afraid of it, not to be afraid of epilepsy, and not to be afraid of women having babies. It is absolutely a normal human thing to want to have a baby, and women with epilepsy and families who live with it shouldn't be excluded from that. It's just simply about getting the appropriate advice, getting and being on the appropriate medication, and ideally seeking neurology and obstetric opinion early if possible. And also to reinforce to women, and I think this is really important, as I've said, we focus so much on the risks to the baby with anticonvulsant medication, and there are, although the risk is still like 2 to 5%, and the newer meds are actually even better than the older ones. So things really changed over the last 20 years with the newer anticonvulsant medication, but also to reinforce that controlling the epilepsy and avoiding seizure activity and looking after yourself and looking after the woman is really, really important. And not to, a lot of women just feel that they'll give up everything for their baby, they'll sacrifice themselves, if you like, for the benefit of their baby. And they need to have reinforcement that most of the meds now are safe, they can be appropriately monitored, and having uncontrolled seizure activity is dangerous in itself to the fetus and to the mother. And so the importance of good control with support and with taking taking action to avoid complications is crucial. So not to be afraid of epilepsy, and not to forget that epilepsy management and getting it under control is really, really important.
And of course, that other message, of course, that it is about mum and baby. Yeah. That's really fundamental here.
Yeah. And, you know, for a lot of women especially, they want to just have the normal experience of motherhood, and that can include driving. So for a lot of women who've been seizure-free for 2 or 3 years, to suddenly then compromise that and end up losing their licence is a really, really big thing. So it's a very precious thing to have a driver's licence, and it's a precious thing to have your health. So, you know, we just say, you've got to, you know, you want to have the same interactions as everybody else, be able to drive your child around, and you can do that.
Dr. Amber Moore, thank you so much for being part of this medical life.
It's a pleasure. Thank you.
Professor Mark Cook is a Melbourne-based consultant neurologist who is internationally recognised for his expertise in epilepsy. He's trained in London and completed his medical doctorate as a brain research fellow at Queen Square. Professor Cook is the Director of Neurology and Chair of Medicine at St Vincent's Hospital, Melbourne. In 2023, Professor Cook was awarded an Officer in the Order of Australia for distinguished service to neurological medicine and research through contributions to the treatment of epilepsy. Professor Mark Cook is our guest on this Medical Life podcast. Welcome, Mark.
Morning, Steve. Thanks for having me on board.
We are looking forward to this in great anticipation, and I'd like to start with the opening question. Does pregnancy alter the underlying chemistry of the brain?
Well, sure. There are hormonal changes, obviously, with pregnancy, and these do have some effect probably on neurotransmitter systems and could potentially affect seizure activity via that means. In fact, that's not such a common problem in real life.
Does pregnancy have any impact on epilepsy symptoms?
Well, the old story used to be, and you know, when I was a trainee, the story was that a third of people got better, a third got worse, and a third stayed the same in pregnancy, which means that nothing happens. And I think that's pretty much true. So there's a dreadful amount of anxiety, and people are often told to expect their seizures to get worse in pregnancy, but that's really not been my experience. And I mean, there are exceptions, but it's true of people with epilepsy generally that the condition fluctuates in frequency and severity from time to time. And I don't think there's any strong relationship to pregnancy.
When is the ideal time for a patient who suffers from epilepsy and considering pregnancy to come see a neurologist?
The very first time they see someone about their condition is the right time. So you should start as early as you can, because most usually patients come and see when they're already pregnant. And so you need to start educating people very early on. And I guess the key themes there are that most people will have their pregnancies completely normally and without any disturbance whatsoever. And the other is that they need to know that some of the drugs carry particular risks. And that needs to be outlined at the very beginning, because, it's always a lot of panic when people discover they're unexpectedly pregnant. I mean, panic for all sorts of reasons, obviously, but often the doctor that they see will be unduly concerned about the anticonvulsants, and this will instill great fear in the patient, and that's terrible.
So can you tell us about some of the common medications that people will have anxiety about, just in general?
Well, look, they worry about all of the anticonvulsants. It's surprisingly common for me to see patients who are told by their doctor that they might have to have a termination because they've gotten pregnant on their anticonvulsants, and that's just not true. Many of the anticonvulsants carry an increased risk in pregnancy. And I guess the main ones that we're concerned with are valproate. So sodium valproate carries a very particular risk and a very special risk. And that risk is very closely connected to the dose. So bigger doses of valproate, above a gram a day, are very strongly connected to an increased risk of malformations in babies. So that's the most important message. Other drugs, though, like phenytoin and the barbiturates, also carry an increased risk. And recently, figures have suggested that topiramate carries a more significant risk than many of the other anticonvulsant medications. Many of them, though, do carry an increased risk, but generally it's a small increased risk. I think people need not to panic about that, but they need to understand it.
So this is a case where, yes, there can be risk, and erring on that side of caution is admirable, but there is nuance, and that's where someone like you comes to the fore to pick out what is of dominant risk and what isn't.
Absolutely. Because, ideally you would see people long before they got pregnant, and you would seek at that point to get everyone down to the minimum, if they're of childbearing years particularly, get them down to the minimum dose of medications that they require and the smallest number, because increasing numbers and increasing doses are associated with increased risks. The other important thing, of course, when you first see people, is to remind them that folate supplements are essential and should be taken as soon as pregnancy is being considered.
If someone does become pregnant and you've actually probably put that risk into perspective, would you still say a patient who's come to their GP who is pregnant unexpectedly, does that warrant an urgent referral to the neurologist with the kind of anxiety that needs to happen?
Look, it almost always does require an urgent referral because of the great fear that people experience in that situation. So there's a lot of panic, and often you need to see them chiefly for reassurance. Most of the malformations and the serious ones occur in the first 12 weeks of gestation. And so you see people after that point. There might be still some advantage in reducing the drug doses, particularly those that have been associated with adverse neurodevelopmental outcomes. Again, valproate and phenobarb are top of the list there. But it might still be useful to reduce the doses. And often people are taking inappropriately high doses and have been for a long time, and you might be able to get them down to a more realistic dose for their pregnancy. Now, you've got to balance that against the risk of seizures, of course, and people are dreadfully concerned as well about having seizures when they're pregnant. In fact, seizures aren't such a big risk to the mother or baby early in pregnancy. Later in pregnancy, of course, seizures with falls and injuries, and of course, if you're driving or engaged in some other dangerous activity, constitute a very real risk. So you do need to be careful about seizures as well. It's a time of life, I guess, where people tend to be more dependent on driving because they're going to all of these appointments and getting everything ready for baby's arrival. And, it's the last time you want to upset people's ability to drive. So that needs to be factored into the considerations as well, because the changes that you make might have other consequences.
Do some of the newer anticonvulsants have the same risk profile as some of the older ones?
The newer ones generally are a bit safer. So I think we regard lamotrigine and levetiracetam as amongst the safer agents. Lacosamide, on available data, and it's still pretty scant data because these drugs haven't been around all that long, and finding people who are taking them in monotherapy who have become pregnant, who you can follow through the entire pregnancy and get the figures on this, are still relatively small in number. But so far the lacosamide looks pretty safe.
Are there any medications that patients should just avoid?
Well, yes. I mean, there's a very strong preference now not to give young women of any age or any state of preparedness around conception valproate. So there's a great desire to stay away from it, which is a pity because valproate, of course, is an extremely effective drug for the idiopathic generalised epilepsies in particular, which are very common in young people. And so there's a problem there of trying to find a balance and drugs that work as well. And that can be a challenge. And sometimes people end up having to take valproate. But as a rule, the valproate should be avoided in women of childbearing age.
With a patient who is pregnant, does their management of epilepsy then change? Do you need to see them more frequently, or is this just goes about the course?
You generally go about the course. I like to see them, early on, obviously, and then towards the end of the pregnancy. Some medications levels will alter during the pregnancy significantly, and lamotrigine is one in particular where the level can drop quite significantly through increased renal excretion, and that's something which might need to be increased quite significantly in dose. Generally, we don't use anticonvulsant drug levels for monitoring therapy, but this is one instance where having an idea of the lamotrigine level early might be useful in giving you a target to try and keep the levels to along the line. Although many people just increase it in the last trimester when this effect takes place most dramatically by 100 milligrams or 200 milligrams, depending on their total dose. But that needs to be corrected once baby's been delivered because physiology returns to normal pretty promptly after that. So another good time to see them is not long after they've had their baby, or again, you can wrap this into one getting close to delivery so that you can have a good discussion about sleep. Because as whilst I've said, pregnancy itself doesn't tend to upset epilepsy terribly. After you've had your baby is a more difficult time often because of sleep disruption. And there's nothing like sleep disruption to provoke seizures. So discussing, if appropriate, rescue therapies for that. Sometimes benzodiazepines such as clobazam and clonazepam, which provide very good short-term seizure control for most people, but are a bit sedating, can be very useful to have on hand, for example.
Mark, just before you mentioned that after birth, physiology returns to normal pretty quickly, is there any lingering concern about breastfeeding and these drugs that you're talking about? I know that.
I'm glad you brought that up. I was going to continue that with that discussion there, but that's a really important point. So there's relatively limited work around breastfeeding and its safety, but it does seem to be very safe. Now, a lot of these anticonvulsants get into breast milk, but generally baby's been exposed to them throughout the pregnancy anyway. And the levels that they're getting seem to be smaller. So there don't seem to be big risks associated with breastfeeding. And I reassure patients that it's fine to go ahead and breastfeed. One thing you have to be careful of is giving a new drug when people are breastfeeding, because babies might not have experienced that. And that might be especially true of the benzodiazepines. In fact, I rarely see it cause a problem, but it is something to make sure that mothers are aware of, that if they're breastfeeding and you've been giving them a new benzodiazepine because they're sleep deprived, it might affect baby a little too. And it's not something to be unduly worried about, but it is something to be aware of.
What's the most common question pregnant women will actually ask you?
Most pregnant women are worried about whether they'll be able to confidently manage their baby once it's born because of their epilepsy. And I always tell people it's really rare for people with epilepsy to have problems managing their children. And it's a really striking feature, really, that although people can be very badly affected and it brings about great challenges in management for many, they're able to bring up children almost always without problems, and they need really strong reassurance about that. People with epilepsy, once upon a time, were often told that they couldn't or shouldn't get pregnant. And even when I started practicing, I would still have older patients who were told that they never had children because they were told that they couldn't and it would be dangerous for all involved, which is very sad and very far from the truth. And that's an unfortunate historical element which still lingers in a lot of doctors' minds, that it's a dangerous process getting pregnant when you're epileptic. And we need to get rid of that idea. We need to be able to reassure people that things are going to go pretty much as normal. There's some special measures you need to take. So I spend a lot of time trying to address those concerns, trying to reassure people that it's going to be pretty much business as usual, but that we need to take some sensible precautions and understand what risks there are and try and minimise them. For instance, bathing babies alone might be dangerous if your seizures aren't very well controlled. Changing nappies on high surfaces and so on. So there are simple things that people can manage if their seizures aren't so well controlled when they have children.
If a lady has epilepsy, what are the chances her child will have epilepsy? Does that come up at all?
Yeah, it does, but that doesn't really come up so often as a question. For some patients who have very strong family history, that's a serious concern. And of course, there is an important genetic component to many epilepsies, but in fact, that rarely intrudes into the real world. So the risks are still really small, so the likelihood of you having epilepsy because your parents have epilepsy is still very small. It's greater than the background population, but I reassure people that, like the malformations related to the drugs, we're talking about very small risks.
Is there anything to be aware of during different trimesters for patients?
Really only that in the last trimester, there's that change in the metabolism of some of the medications, but particularly lamotrigine. That's the only one where it probably has a big impact. The other important change, I would say, from a practical perspective, is that in late pregnancy, sleep is often very disturbed, just because people have trouble getting comfortable in bed. And that's a time where it often causes a lot of stress, because people are aware that if they're not sleeping properly, that they're at greater risk of seizures. So trying to manage that can be a problem in the last trimester. But outside that, of course, if people have got the hyperemesis early on in pregnancy and they're not retaining their medications, that's a problem. But again, not such a common issue.
If in early trimester patients have morning sickness and are vomiting a lot, is that a problem with medications?
Well, it can be if they're not holding their medication down, but I very rarely encounter that as a significant problem. It is a time when it might be useful to have some rapid-acting rescue medication around, like, benzodiazepine. But again, very rarely a practical issue for me. I might just add to that like with vomiting in general, if you vomit within half an hour of medications, or there are visible medications in the vomitus, that's a time to either take the medications again or seek your rescue therapies.
Now, you mentioned just the child who may get little bits of medication during breastfeeding. Is there anything with regards to the management of the child after birth that's going to be important?
There doesn't seem to be. I mean, I've not come across any particular problems. I did have a patient once whose infant wasn't feeding very well, and she was taking topiramate at the time. And topiramate's a powerful suppressant of appetite, and it was always a question as to whether the topiramate might have been contributing to that. I haven't seen on other occasions, and interestingly, I subsequently advised many patients about that, and then they always said to me they never had any trouble. But most of them then later told me that they never actually ended up reducing the topiramate.
Look, just finally, is there any advice or comments that you have about managing epilepsy in pregnant patients?
Advise all women of childbearing years with epilepsy to learn as much about it as they can, to understand that they'll have a pregnancy which will almost always go ahead totally as normal and without any hiccups. Everyone needs to be on board and understand the situation, and there needs to be good correspondence between the neurologist and the gynaecologist, obstetrician involved in their care. I think that's really critical, because having involvement directly between those two parties will see that everyone's got a good understanding of the risks and hazards, and the obstetrician can let you know particular problems, if they might need to do an early delivery, if a seizure is more appropriate, when we're getting into trouble with sleep patterns, things like that. And having the obstetrician confident about dealing with people with epilepsy is the single most important thing in the whole process. That is what I advise people with epilepsy. Go out and find an obstetrician who understands it and who isn't going to worry, because you hear terrible stories of anxious doctors and patients getting themselves in a bit of a tangle because no one really understands what the risks are, and people aren't communicating with them. So it's important for the neurologist to be very proactive in that regard and get in contact early with the obstetrician. So I like to establish that early with the patient. I tell them all that, and I'll be in contact with the obstetrician, and they should contact me directly if there are any problems whatsoever.
As you were talking about the importance of all that cross-communication, I had an image of the old Rock Hudson, Doris Day movies where there were party lines and you pick up the phone and everybody was on the phone together. It's almost like that would be an advantage.
It definitely would be. It definitely would be. And, isn't it one of the paradoxes of modern communications that we have all this social media and emails and things, and yet communication between doctors and their colleagues is still at something of a premium.
Yes. Professor Mark Cook, thank you so much for being part of This Medical Life.
My very great pleasure. Thanks for having me aboard.
Anna Heldorf was diagnosed with juvenile myoclonic epilepsy at the age of 17. After several years of trialling different medications to find a treatment protocol that works, Anna now has her epilepsy well controlled. Anna's currently a public servant in Victoria with professional experience across a range of sectors, including public, private and not-for-profit, and has policy and program experience across a range of policy areas, including family violence, mental health, housing and children and families. She has a Bachelor of Arts as well as postgraduate qualifications in international relations and social impact, and in January Anna completed a Master of Social Policy at the University of Melbourne. Anna had her first baby, Esme, in April of this year and lives in Melbourne's north with her partner Ryan and her cat, Biscuit. Anna is our guest on This Medical Life podcast. Anna, welcome.
Hi, thank you so much for having me.
Anna, you're a couple of months postpartum now. How did you find the experience of pregnancy and managing epilepsy?
It's challenging. I think one of the more challenging aspects is that often when you see people find out that they're pregnant, especially if it's something that they've been trying for and have had a difficult journey getting to that point, which was our experience, you see kind of, an image of seeing the pregnancy test and, jumping for joy and jubilation and that sort of thing. For me, it was not such a straightforward kind of step from finding out I was pregnant to experiencing joy and being really excited, because knowing the complexities around my epilepsy and needing to manage that safely during pregnancy for my own well-being, but also for the well-being of the then fetus and now my beautiful baby girl, Esme, kind of just makes it all a little bit more complex. So for me, it meant I decided to stop taking one of my medications, which meant that I had to stop driving for a period of 3 months, which for me meant, a loss of independence and quite a significant change to life, and as well as all the regular anxieties that go with making any change to medication. So I guess, it was something that right from the get-go was a little bit more fraught. Obviously it was still really, exciting and special. I think also personally, I was sort of undertaking research and writing my thesis to complete my master's for most of my pregnancy, as well as working 4 days a week. So it was kind of quite a busy time, and sort of managing all of that around, the tiredness that goes with the first trimester, and then the sort of discomfort and sleepless or not sleeplessness, but interrupted sleep that comes later on was quite challenging. So I feel like I probably didn't really get to experience and sort of enjoy feeling pregnant until I was on parental leave, because then I'd sort of stopped working, I'd finished my thesis, and I just got to really, be pregnant and feel all of the joy that comes with that. So yeah, it was complex. I would say I had the enormous privilege really of having a really fantastic care team. So between my neurologist, Mark Cook, who I believe is on the episode, and Amber Moore, my obstetrician, I just felt extraordinarily well cared for, and that both of my specialists really had my best interests at heart. I think what can happen for people when they are pregnant is that there can be such a focus on the fetus and the pregnancy and the baby to be that the pregnant person gets kind of lost in the mix, and it can be an extraordinarily disempowering and traumatic experience for some people. And I am just really conscious of how focused on my health and well-being both Amber and Mark were throughout the entire pregnancy. And that's, I think, a testament to them as medical professionals, and also I think a really important part of providing quality care generally, and especially for people who are also managing chronic health conditions, because, the health of the pregnancy and the fetus, or then post-birth the baby, is really dependent on the health of the person who's, carrying that baby and then caring for that baby.
Before you were pregnant, did you have any concerns about epilepsy and having a family at all?
Absolutely, yeah. So one of the medications that I was taking is Epilim. And so if you're a person who's capable of getting pregnant and take Epilim, you can't avoid the conversation that a doctor will have with you about how risky that is, because of the history of Epilim and what we now know about the increased risk of a range of birth defects. So that was something that I was very keenly aware of and really, really concerned about. That was my primary focus, I suppose, I think, because those conversations are sort of had pretty much as soon as you go on Epilim, and then as someone who's always wanted to have a family, that's sort of always been in the back of my mind and been a huge concern for me. So a lot of sort of fears and anxieties about that, and sort of contemplation and thinking through, and I guess the fear of going off something like Epilim, if you know that it's been a really effective drug for you in your seizure control, is that then you will have seizures while you're pregnant, and then that's also incredibly risky for a pregnancy and for a baby, especially primarily once you're sort of in the later stages and you're bigger and it's associated with the fall risk. But also it comes with a huge disruption to your life, losing a license, and just the kind of the recovery after having a seizure. I personally have tonic-clonic or grand mal seizures, so they're can be really quite significant in the way that they impact me physically, emotionally, psychologically, all of that sort of stuff. So balancing that risk against the risk of the increased risk of a range of birth defects if you take Epilim during pregnancy. So part of that can come, feelings of selfishness and guilt can come up, and sort of projecting into the future. And, if my baby were to be born with one of those birth defects, would I forever carry the guilt of knowing that I chose to continue that medication, even though for me that was maybe the right choice at that time for my safety as well as for hers. So it's kind of a really complex web of questions that are all about some sort of potential situation that may or may not present. Risks are risks, they're not certainties. And I think that's one of the really difficult things about navigating that, especially as someone who's not a medical professional. I think I'm relatively health literate in that I've had to manage a chronic health condition since I was 17. My mum is a former physio and has a master's in public health, so has worked a lot in public health, so there's always been a lot of health chat in our house. But, it's still, I don't have, medical training, so understanding that, I think one of the things that Mark was really, really helpful at explaining to me was that there is a general population risk for everyone of all of these conditions. When you take a drug like Epilim, it increases that base level risk. It doesn't sort of create some kind of certainty that condition is going to present in a baby. And, it might increase that risk from 2% to 4%. So you've still got a 96% chance that you're going to have a perfectly healthy baby. And so I think when you're kind of in that space, it's really easy to get focused on the negatives, I suppose, because you're so kind of risk averse and trying to make the best possible decision for your baby as well as for yourself.
During your pregnancy, did you have to have regular neurology appointments, obstetrics and gynaecology, and GP, more than what you would probably expect for pregnancy? Did you feel that was actually a real increase?
I certainly had a few more obstetric appointments, and I think one extra neurology appointment with my neurologist. Because my epilepsy is well controlled and because I didn't have any issues, even though I did change my medications throughout the pregnancy, I was really lucky that didn't end up in increased seizure activity for me. So obviously if I had post one of those changes had any seizure activity, then that would have led to sort of triggered, more proactive sort of management of that. But yeah, with my obstetrician, Amber did see me a bit more regularly, and I had a couple of extra scans just to check that, some of those risks, to check in about some of those risks early on and then later on as well.
Now, you've had ESME. Has there been any changes that you've had to have after you've had ESME?
No, so I've just continued with the medications that the medication that I was taking for my epilepsy postpartum. Part of that is about reducing the likelihood of having to go through all of those changes again if we choose to have a second. And given that I'm getting sort of a safe level of seizure control, Mark's very happy with where I'm at, and I've been sort of cleared to drive, and so I'm kind of back to business as usual, which is really, really great, especially, being able to hop in a car with a baby is pretty handy when you need to get to all of those checkups and things. So I've been really, really lucky to have not had any seizure activity thus far, and therefore not needed to make any changes. Touch wood.
Just as you mentioned driving, I remember driving our first child home from the hospital. It was the single most nerve-wracking driving I've ever undertaken. I guess there'd be even extra profundity in your case.
Yes, well, that was my partner Ryan's job. I had a cesarean, so I wasn't allowed to drive anyway, and probably shouldn't have with all of the painkillers I was on. But yes, I'm pretty sure he was terrified. Yeah.
Is there anything that you know now that you'd wish you'd known either before or during the pregnancy?
Don't try to work a near full-time job, do a thesis and be pregnant all at the same time. I'd say don't do that ever. One of the things relates to kind of what I said earlier about experiencing really a range of thoughts and emotions about pregnancy and birth and having a baby. And I kind of wish I knew that beforehand and knew that was okay. There's no bigger change to your life, I don't think, getting pregnant and then having a baby and becoming a parent for the first time. And I think it's okay to have, whether you have epilepsy or not, it's completely normal and okay to have a range of feelings about that, and that doesn't make you selfish or, doesn't say anything about you. It's completely normal. I would say that there are actually some some benefits to having to manage a chronic health condition when pregnant, and mostly for the post-birth phase. Because sleep, for example, is such a massive factor in epilepsy and sleep deprivation specifically, and it's also such a common characteristic of early parenthood, we had to do a lot of thinking beforehand about how we were going to manage that and what that might look like in different scenarios. So we agreed very early on that Ryan would help with overnight feeds and wake-ups and things like that, because I need to have sort of blocks of sleep. And so that meant that we had thought through a range of different scenarios and how we would approach them ahead of time, and made a plan for Ryan to take that role, which has actually been really lovely, because it means that from her birth, he's been, doing some feeds and has like a really active and critical role in her care, which I think has been kind of beneficial for him, because I know that early time can be quite challenging for dads or for the secondary caregivers to kind of figure out where they fit into this new dynamic, which can be a bit like mother-baby, centered. But it's also meant things like, we've had to think about, how will I change Esme when Ryan's not at home? If I'm at home with her, how do I change her? Because worst case scenario, it's very unlikely, but if in worst case scenario and I have a seizure when I'm changing her, it's important that she's not up on a change table where she could roll off and get really seriously injured. Similarly, we've had to, think about how we'll manage bath time, because again, that's not something that's safe for me to manage in that worst case scenario.
Anna, if Esme would indulge us one last question, is there any advice you have for doctors or patients about epilepsy and pregnancy?
Absolutely. I think for patients or people who are pregnant now or wanting to get pregnant, I would really recommend, if it's available to people, and I know it's not for a lot, to access a private specialist, particularly for the obstetric care, just to have that continuity of care and know that you're always seeing the same person, and to find someone fabulous like Amber who has experience with managing a condition like epilepsy as well as pregnancy. And for those people who don't, I'd say, what are other ways that you could feel more supported through your pregnancy and postpartum experience? Because I think, the doctor-patient relationship can be sort of inherently a bit of a power imbalance. I think, I'd recommend something like always having your partner or another support person go along with you who can really be your advocate and, I guess just be there to back you up and make sure decisions are being made with your best interests at heart, or at the centre of them. And also access, free services that might provide, advocacy or just advice through this period, because it is really hard and it can be really overwhelming if you don't have access to the information that you need. In terms of for medical professionals, I would say focus on the pregnant person, and their health and well-being should be the first priority. I think treating pregnant people as sort of a vessel for a baby can be a really traumatic and disempowering experience for that person. And as I was saying before, their health and well-being is, perhaps the single biggest contributor to the health and well-being of the baby. So it's really important to keep that front of mind. And I think the other thing that, is really important is kind of that balancing risk, particularly around medication, but around everything is about balance. It's about what are the, if, as I sort of mentioned before, if there is a risk associated with a medication, there's also a risk associated with not being on that medication. And it's really important to sort of understand that rather than jumping to the worst case scenario and kind of pushing for, a decision about a medication that might not actually be in the best interest of the pregnant person. based on sort of understandable fears and anxieties, but some that may shifted in recent years, with recent research, or whatever may be the case. So, I think really just focusing on the best interest of the pregnant person is kind of the key takeaway for me, and making sure those conversations are had in a really sort of sensitive way that makes them feel supported and empowered to make decisions about their health as well.
Anna Heldorf and Esme, thank you both for being part of this Medical Life podcast.
Thanks so much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.